circumstance. Many of our other governmental clients have found themselves in unique circumstances as well, and where we can provide assistance from leadership, merging together technology, finance, operational experience to make dramatic change in very short periods of time. And then turn to the presentation we have in front of us as well. Our scope of work is primarily driven across 4 areas: providing leadership in finance and operational services, budget and forecast support services, organizational redesign, and data governance. We've talked about, through the discussion already this morning, some of those areas. In finance and operational services, we're providing day-to-day support for financial functions, and that means day-to-day things that hit the ground, personal care services, managing the process around drug rebates, supporting CMS certifications, providing audit support, the activities that Dr. Cummings mentioned around contract analysis, looking at the spend, looking at fiscal impact analysis associated with policy changes and potential legislative changes. Part of what we're delivering on top of day-to-day support are revamped policies and procedures that will set forth a standard for how the finance function will operate after we're gone, and making sure that before we leave that those will be trained on, and that staff, DMA staff, will have a working knowledge of how to enact those policies and procedures and how to work in that changed environment. Also, we're working on developing contract management practices and better oversight practices as well. As I mentioned, there's a transition aspect to everything that we do to make sure that what we do in terms of change sticks. In terms of budget and forecast operational services, the majority of our focus has been changing the way the budget and forecast model is constructed and making sure that that is a much more robust, data-driven process than had been in place previously. And that will provide a better standard for financial forecasting. Some of the other activities that we undertake are review of financial accountability for programs and support for the year-end close. I want to highlight that in looking at financial accountability and with the theme that was discussed earlier around collaboration, our staff has been meeting with every program in Medicaid to really look at how program delivery ties with financial impacts. And that had been not undertaken for many years, and it's been a very time-consuming process, but one where we really merged the understanding from the programmatic side, the way you deliver services and what the fiscal impacts are for those services. And that means working through program by program and with every individual in DMA to really understand the changes they make, the way they deliver services, any impacts and fluctuation that could occur. As I mentioned, we will be developing and are now currently testing a new financial model that will be supported by its own operating policies and procedures and an overarching budget management process. That transition will involve transitioning to the use of that new model and the testing and support for it. Another key area that we've been working that has been mentioned and think through discussion this morning has been on the organizational redesign specific to DMA. As highlighted, it's been over 40 years since the overall division has been looked at from a design perspective. And one of the key areas we'll highlight, and that's been highlighted by Dr. Cummings, was around business information. Nowadays, because we have technology, we have so much information to work with, this was a key area that was buried under multiple layers of organization and needed to come to the forefront to be the center point for collaboration to support decision making. Additionally, we've been working closely with OSBM on a redesign proposal for DMA, stressing collaboration, stressing accountability, performance measures, and with being very mindful about giving individuals in DMA a place where they understand how to grow their career and understand what their responsibilities are, so they know when they're doing well and they know what's expected of them to successfully contribute. Some of the outputs of that effort are the redesign itself, job description, support for Mark Ogle's team and helping with recruiting efforts, reviewing the appropriateness of roles and reporting relationships, many questions that have been asked this morning. Finally, another area that we have been working to support is around data governance. This is an area that we haven't taken an initial look at from a reporting relationships and scope of work, the interaction between the DHHS CIO and within DMA, but we have yet to get started per our timelines to look at some of the other areas within this scope, and that would be specific around supporting Steve Tedder and his team around some of the data challenges, specifically as they relate to the fiscal model, providing reconciliation support for the historical implementation of data into that model, and providing a governance strategy and framework. It will be helpful to the team on the ground at DMA, providing a data governance plan for implementation going forward. So that highlights overarching parts of our scope of work. I'm sorry.
Go ahead.
It's okay. I wanted to go ahead a little bit further to show some of the areas that we've been working through initially. As mentioned, one of the areas that was recommended based on our first few weeks at DMA was highlighting the business information function. As noted, there's an inability to quickly provide data for business decisions. The approach was to reassess the roles and responsibilities of the DHHS CIO and understand the requirements within DMA specific to information decision-making and coordination across the programs, as well as working with finance and other key areas. The organization has been realigned to create a new position and a new group specifically focused on business information with a direct report to the DMA director, with Dr. Cummings receiving that information and that coordination immediately. We found that on the ground this has resulted, as was highlighted, in more data-driven decision-making and analysis. We've recruited a senior executive with a demonstrated track record of technology innovation and Medicaid data management into this role, which is very critical. And said that the impact has been very significant and very quick in terms of being able to fill data requests and be able to be a key player in bridging operations with decision-making. Additionally, one of the other areas we wanted to highlight that's been a focus of some of our efforts has been around drug rebates. We are currently coming upon the next deadline later this month for the drug rebates invoices to be paid, but we anticipate a dramatic increase in collections by the deadline as compared with prior quarters. And that is because we've been very proactive in analyzing how historically invoicing was performed and how collection patterns were experienced by DMA. We've done a lot of reach out. We've created a monitoring process. We've identified specific laborers who have been not timely in their payments. And historically, those late payments resulted in borrowing from state dollars to cover those expenditures. We do not expect that to happen this quarter, and we expect to have very significant change because of the proactive nature of working through this process. So those are just two areas that we've highlighted where we see changes on the ground from a day-to-day perspective, and there are many more, and we'll talk more obviously this afternoon about some of the financial impacts and how the model will be used going forward. Finally, I just wanted to highlight some of our experience working in health and human services, where some of the approach that we deliver services with DMA emanate from. And as I mentioned, to begin with, worked with the Commonwealth of Pennsylvania and its Department of Public Welfare, with the state of South Carolina, the Department of Health and Human Services overall, and specifically with the Medicaid program, the state of Maryland and health and mental hygiene, working with other states, similarly, whether Commonwealth of Puerto Rico is a territory, currently with the state of Louisiana across all government agencies, and many other healthcare organizations where we have responsibility for providing, in many cases, restructuring support and interim leadership. So with that, I'm happy to address any questions that you may have.
Let me start just to get some additional information if possible to understand. If we can go back to your first slide. And within that slide, could you just kind of cover for the committee which of those, what of those items were part of your original contract, I guess that started back in January, versus what new items were added into your expanded contract?
Certainly. Originally, part of our contract was to support the plan for reorganization, but it was limited to finance and data analytics. It has expanded to look across all functions of DMA, so that's where your point of expansion. We were within just finance and the data analytics, we were looking at job description and recruiting efforts, but that has expanded across all DMA. The expanded scope really focuses on the extent that we're providing support from finance operations under the direction of DHHS's CFO. And overall, the expansion also highlights some of the roles associated with budget management, not just the development and implementation of a budget model, but providing day-to-day leadership support in that area as well, to have responsibility for areas like drug rebates and the PCS area. So those were some of those key areas, as well as the data governance area.
How many, under the original contract versus the expanded contract, how many individuals were on the ground in the original contract versus with the expanded scope for it that you have?
I think contractually we've expanded by about 3 FTEs. In practice, we have expanded by more than 3 FTEs. Overall, we have additional folks on the ground, especially as critical budget period is in place.
Thank you. Chairman Heiss?
Thank you, Mr. Chairman. First, you talked about some other states. What's been, for this contract, what's your scope of work in North Carolina compared to what your scope of work has been in other states? And what is new to this contract, or what's been specifically done elsewhere?
Sure, let me start off by speaking with experience in a contiguous state in South Carolina. We were asked to support the Secretary of Health and Human Services, Tony Keck, when he came into that position. He came in and a few weeks after starting and being confirmed in his role, found that they were about $250 million in the hole from a budgetary perspective, and had to come to the state legislature for a supplemental increase. And his general sense was, 1, I want to figure out why this happened to make sure it doesn't happen again, and 2, I'm not doing this again. I'm not coming back to the legislature with a surprise. So we took on a role to play an interim role for budget management, as well as implementing a new budget and financial model, and putting in place and training the South Carolina DHHS personnel on how to implement that model and bridging that gap. So that area was very similar to the role we're playing here in North Carolina. I would say that our role here is expanded to look more at data governance, and with the implementation of new systems in the state, play more of a role looking at reconciliation and data changes. Additionally, in South Carolina, we looked at reorganizing the financial functions. Here we're providing probably a little bit more support of reaching beyond financial functions to look at the reorganization and recommendations for reorganizations across DNA.
Follow-up?
Looking at really this business information function, and 134 data requests during the budget months doesn't surprise me significantly that was coming in. But what does surprise me is, and take a question that's been very difficult to answer, to get answers from, or to ask, how many enrollees do we have in Medicaid? How many of those are children? How many of those are age-blind disabled? From your own, one of those, and that's one of those requests that's got it out there. From a beginning point of saying it takes 2 to 3 days to answer that question, we'd love to have had the answer in 2 to 3 days, but long term, what's a reasonable timeline that we should be able to get those type of answers back when asking basic summative questions of the Medicaid population in this state and trying to receive that data back?
Again, my experience working with other states, that typically kind of operational questions can be answered within